Good evening, everyone. Am I audible and clear? Can someone please confirm?
Yes, ma'am, you're audible.
Yes, ma'am.
Thank you so much for confirming. So this is Ripriya. I'm sorry that I'm not visible to all of you because I'm sitting at the side. This is Ripriya along with Mr. Ambadi and Dr. Arjun Devarajan, welcoming you all to the 31st batch of a foundation course in palliative medicine. Mr. Ambadi will be working as the coordinator for this batch, and Dr. Arjun Devarajan along with Dr. Hashmat will be the facilitator. Saying about Dr. Arjun, he is a senior palliative care physician currently serving as the section head of medical services in Pallium, India, and he is also servicing as a consultant palliative care physician at PRS Hospital, which is a prominent private sector hospital in Kerala, Trivandrum. Before we move on to the formal sessions, we just wanted to give you an orientation about the entire training process. So, Pan India, as of such, works upon the model of demonstrate, educate, and facilitate, where we demonstrate the entire palliative care. What is palliative care? So, the entire thing we demonstrate through Trivandrum Institute of Palliative Sciences TIPS, which is headquartered in Trivandrum, Kerala. TIPS is a training and education wing of Pallium India, and we conduct training and educate doctors, nurses, allied healthcare professionals, volunteers, students, palliative care beneficiaries, specialists, and many more. We are in collaboration with Project ECHO, which is the extension for community healthcare outcome. And through ECHO platform, we are looking forward to build the capacity of healthcare professionals and spread the awareness among masses regarding palliative care. These are some of the ECHO programs which is being listed here. You can definitely go through the list in our website as well. Coming to this specific batch of foundation course in palliative medicine, we have 20 sessions of prescribed syllabus-oriented sessions. Our start date is today, 1st of January 2024, and we'll be ending the 20 sessions on 23rd of February 2024. We'll be having 3 sessions per week, Mondays, Wednesdays, and Fridays from 5 p.m. to 6:30 p.m. Indian Standard Time. We do have a pre-evaluation and post-evaluation. We hope that every one of you have completed the pre-evaluation, and we would like to intimate that the score of the pre-evaluation will not be considered anywhere for the certification. This is one of the important slides, the most important. The ground rules for certification are minimum 80% attendance of the live sessions, minimum 80% score in all assignments. We'll be having 5 assignments in between. We need all of you to submit a case scenario on time and the submission of pre-test, post-test, and evaluation. Learning materials pertaining to each session will be uploaded to IECO platform, and it will be including the faculty and the case presentation PowerPoints, video link of the complete session, articles, and other learning materials regarding the subject. Certificate issuance is definitely based on your performance throughout the program. We will be having a feedback link for each session, and we encourage every participant to provide us with their valuable feedbacks. All communications from our end will be made through email, tipsecho@palimindia.org or the WhatsApp group. These are the special points to be noted. Just stressing once again, TIPSECO is conducting all the sessions through IECO. Each session will be having separate links, unique links for each participants, and those will be delivered in email, WhatsApp, and SMS exactly 30 minutes before the session start time. Kindly note that all of your attendance is directly linked to the unique link received, and hence we would strongly recommend not to share your link with anyone else because it would result in loss of attendance. This is the general structure of a 90-minute program. First 5 minutes will be general introduction of the faculty. The next 40 minutes will be presentation by the faculty, followed by 15 minutes of discussion on that presentation. Following that, 5 minutes will be having a patient story presented by one of the attendees. Today we will be having a model case presentation from our end, which will be presented by Dr. Arjun. The last 25 minutes of the session will be discussion based on the patient story. These are the terms of engagement for the Zoom meeting. Since everyone is already well aware about it, I am not going through the details. Thank you so much. So with that, and wishing everyone a happy and prosperous new year ahead, I'm handing over it to Ambadi to formally welcome our facilitator and then further coordinate the session. Ambadi, over to you.
Thank you, madam. And Happy New Year to you all in advance. Sorry, New Year. And I am welcoming Dr. Arjun sir for the facilitation part to continue the session. Over to you, Arjun sir.
Thank you, Ms. Vidya. Happy New Year to all and welcome to new session of the program. To start, let me introduce Dr. Vidya Viswanath, a faculty for the day, Assistant Professor, Department of Palliative Medicine, Homi Baba Cancer Hospital and Research Center, Visakhapatnam. She's also an honorary tutor at the School of Medicine, Cardiff University. She's a faculty with IUPC, Pallium India, CTC training, APHN, Leon Foundation, and AIMS Delhi. Besides this, she's a palliative care champion who is actively working alongside the government of Andhra Pradesh for integration of palliative care in the state's public health system. Over to you, madam.
Thank you very much for that, for the introduction, and wish every one of you here a very, very happy 2024. It's very heartening to see that another 50 plus participants are going to be trained in palliative care this year, which really augurs well for palliative care. So please feel free to drop in questions on the chat as I take the session. And of course, we will be having a discussion. So my first 40 minutes will be on the didactic presentation. So could I start? Is that okay to start?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
All right, fine. So I'll just share screen. So when I talk of palliative care, I am really not aware how many of you have had experience in palliative care, how many of you are in this training who have already done palliative care before. And I'm sure there will be a few of you who have never actually practiced palliative care. There may be some of you who really don't know what palliative care and exactly what it means. So being a mixed audience, I would always like to start from what is palliative care. And as far as all of us are concerned, those who work in palliative care, we understand that palliative care is mostly about the illness experience. So in the course of the next 40 minutes, I'll just give you a broad overview as to what palliative care is, what are the interventions that we work with in palliative care, and a little bit about the evolution and the evidence for integration. So when we go back to the basics and start with the WHO definition of health, we understand that health is a state of complete physical, mental, and social well-being, and not just the absence of disease or infirmity. We've heard this from time immemorial. But how much attention do we actually pay to this when we have been practicing medicine is a thought. So that is why it's important to step back and think of what is disease, what is sickness, and what is illness. So when we think of that, we would know that when you say, so suppose a person with jaundice comes into your clinic. For the world and for society outside, this person has jaundice. You may diagnose that patient with either hepatitis or probably a cancer, we do not know. So that is the disease, the underlying pathology, which you define as a healthcare practitioner. The sickness is the social, they say, oh, that person has jaundice, he's unwell. But what is illness? So illness is what the person goes through. So that person, if I ask him, how are you feeling? He may say, I have nausea, I have vomiting, I can't stand, I'm feeling very tired. So the illness is a person's subjective experience of their symptoms, and that has actually brought that person to the doctor. So in our pursuit of medicine, and as we are specializing and as we, with every new advance in medicine, what we are actually doing is trying to break it up and trying to focus more and more and more on the disease, and the illness experience starts taking a backseat. So that's what palliative care tries to bring in the forefront. so that along with disease, you can also look after the illness experience. And how do we integrate it? So this is going to be the essence of my talk over the next 40 minutes. So this in 2018, there was this article in the Lancet, because till then the WHO definition was, everybody thought that palliative care was end of life care, it's terminal care, and you have nothing that you can do. But this kind of changed perception. So it brought into focus what we call as serious health-related suffering. So with this serious health-related suffering, that is when slowly the world started waking up to more than just terminal and end-of-life care. So to understand that, we have to go back and again take a step back and see that all of what I'm going to tell you over the next 40 minutes is in the context of chronic disease. It's not in the context of acute disease. So you have an MI today, you have a fracture, and your next street will have 10 nursing homes or hospitals or doctor spaces to go to. But suppose you are a paraplegic. Suppose you have had an accident that has left you paralyzed. Suppose you have terminal cancer. Suppose you have CKD and you are at home and you are unable to get up, do any of your tasks. Where would you go? In any chronic disease, which hospital will welcome you? If you try and answer this question yourself, you and I know that we have almost no hospitals around that will welcome such a patient. What they do is say, oh, you can go home. We have nothing more that we can do. At the end of a palliative care training, the first thing I would really, really request each one of you never to tell a patient is that there is nothing more that we can do. Because palliative care teaches you that there is always something that you can do. So a chronic disease trajectory is what we are talking about when we talk about all the things that I'm going to tell you. So again, to understand chronic disease, try holding that glass of water. On the surface, it looks very easy. If I have to hold it for a second or a minute or 5 minutes, it's simple. What's difficult about it? But if you want to hold this glass of water 365 days in a year, every single day of your life, then how difficult is it? It is going to cause you immense pain. That is the burden of chronic disease, because you are holding it within you all the time. This is incurable disease. You can have this with cancer. You can have it with multiple chronic diseases. You can have it with old age and frailty. So this is how the trajectory of chronic diseases. You can have a steep evident decline, which is what we see in patients with cancer. You can have intermittent episodes and then a gradual decline. This is what you will see very commonly in your patients with CLD and CKD and chronic respiratory disease or Parkinson's or any neurological disorder. You can have a prolonged dwindling phase, which is what you will see in the geriatric age group. So what is palliative care? Well, WHO says that palliative care is an approach that improves the quality of life of patients and their relatives facing problems associated with life-threatening or life-limiting illnesses. But now comes the good part, through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment. So each word in this definition is important. Quality of life, not just patients, but also relatives. It could be a life-threatening disease. It could be a life-limiting disease. And what do? You don't wait for the suffering to happen. You start by preventing suffering and providing relief continuously along the trajectory of the illness. How do you do it? You identify it early, you assess it well, and you treat it aggressively. So that is what palliative care tries to do. So who needs palliative care? Well, if you want to answer that question, I'm sure each one of you, if you think about it in your mind, start from every system in our body: neurological, cardiovascular, chronic liver disease, chronic kidney disease, chronic respiratory disease, the geriatric population, those with cancer, and don't forget the pediatric population. So, which makes us understand that how much is the scope for palliative care provision and how much are we even doing? And if you look at it in India, you need to train every doctor, because otherwise we will never be able to reach out to our patients in need. So in those with advanced cancers, 70% of cancers need our help. Old age related diseases, people living with HIV/AIDS, and all of these are specific to India. You have immense amount of suffering, which we don't even see. So to understand what we do in palliative care, let us start with a story of one of our patients. Now, being from a cancer hospital, and that's what I work in day in and day out, most of my examples would be with cancer, which doesn't mean that those without cancer do not have palliative care needs. It's just that this comes easier for me. So if I had to tell you a story, then I'd like to introduce you to Mr. Srinivas, who's 28 years old. Now he has come, he has been detected with oral cancer. Somebody has told him, he has walked into our hospital. There is a rapidly growing tumor in his buccal mucosa. And what's the first thing that everyone does? First, you shine a torch, you look straight into his buccal mucosa. And then if the odor is too much, you tell them, okay, tell him to wait outside while I talk to the family. And then you start talking to the family. Oh, well, now he needs a biopsy, he needs treatment, this looks like cancer. And you will have to go through all of these steps. You have to go for imaging, do all of this, and then come back to us. But when you are deliberating all this treatment for this patient, what exactly do you think is happening? Can we just take a pause, and would you like to put something in the chat which will tell me what he's thinking? So anybody, would you like to put anything in the chat? Or would you like to unmute yourselves and tell me, what do you think would be going on through Srinivas's mind? He is anxious, he's thinking of the worst. He's thinking he has family responsibilities, hopelessness, fear, social isolation, shock, as in why him? Yes, very good. So you have identified so many things because you are now trying to relate to Srinivas as a person. What will be my disease? So what you're trying to do is exactly what we are trying to train you to do. So what is going to through Srinivas's mind, as most of you have put in very correctly, is a lot of things. So what are they? You have this whole spectrum. So if you want to divide it, you can divide it into the physical, into the psychosocial, whatever is emotional and spiritual. Remember, these are not bracketed one after the other. I put it like that, but it is more like one within the other. What is evidently visible is on the outside, the physical symptoms, but what is going on in his mind and his thoughts are the rest. So even with the disease, this is a man who has come to you with a tumor growing in the mouth. It has a very foul odor, because of which he's not able to swallow, because of which he has pain, because of which he'll have nausea, he must have stopped eating. And because of the odor, the family members are going to be away from him. So never forget the physical. Don't just think of only the psychological, focus on the physical. Because if you do not ask Srinivas, how are you feeling? He is never going to tell you, oh, I have pain, I have a bad odor, I have, I feel like nauseous. All of these symptoms are something we train to ask. Because otherwise, the word cancer itself is so overwhelming that the family says, what are you complaining of pain? You have cancer, you're supposed to have it. So that is how the perception is. So as physicians, we have to start by asking them open questions. And how are they feeling? What are the symptoms that they have? And then now you're looking at a 28-year-old. So obviously there is going to be role reversal. There is going to be financial disruption. There's going to be social isolation. He's suddenly going to, from someone who has been working all the time, suddenly he is going to be isolated. He is not going to work. He can't even talk properly. And he's going to be anxious. Suppose he was a smoker, he is going to feel very guilty. Why did I smoke when everyone told me not to? Suppose he's not a smoker and he has a disease, he'll say, what did I do to deserve this? So the spectrum is wide. You cannot pinpoint and say this person feels this way, because you have to ask them to know what they feel. One person may feel very differently from the other person. As a physician, you cannot be judgmental about how they feel and what they feel. You still have to ask these questions and still give them You cannot answer every one of these questions, but remember, you are their co-traveler in the journey that they are going to start. And never forget the person who is behind the patient or the caregiver. Because who is a caregiver? Each one of us here is a caregiver. We may be having elderly parents at home. We may be having young children. We may be having so many people whom we look after. Now, if someone falls sick in the house, do you stop working? Do you stop doing what you normally did? You don't. You continue that and you add this to your list. So you might have to add taking the patient for chemotherapy, adding to your work because suddenly the finances are not enough. And then all the house responsibilities were always yours, but now you are adding on another person's responsibilities, and you throw in a lot of terminology on the caregiver: chemotherapy, radiotherapy, imaging, scans, medication, and the person is lost. So that is why palliative care also focuses on the caregiver, which is a very, very important part of care provision. So what do we do in palliative care? We try and alleviate this suffering. We try and bring it down. So we set goals of care, we improve quality of life and provide caregiver support. So how do we do this? One is symptom control. Remember, holding someone's hand is not going to take away the pain. So when we talk about palliative care, it is not just psychological support, it is aggressive symptom control along with all of this. So symptoms must be assessed and managed. And remember, one more rule in palliative medicine is longitudinal assessment, assessing your symptoms every single time they come in. And the symptoms that we manage, yes, pain is the one of the symptoms that's always topmost on the list. But we also manage nausea, vomiting, intestinal obstruction, cough, breathlessness. We have various kinds of wounds that we manage, fungating wounds, then care of stoma, palliative care emergencies too. So all of these are the symptoms that we manage. And how do we approach it? One is medicine round the clock. So it might seem a little strange to you and to the patient and the relative, because all along we have prescribed medications and we say, when the pain comes down, stop the medication. But remember, we were not dealing with chronic disease. So now in palliative medicine, we need to continue the medicine for as long as the disease is there, because the disease is what is causing pain. So explaining this to the patient, taking proper reviews and giving them medication round the clock, talking about breakthrough medications, all of this you will learn in your course of over the next 1.5 months. Maintaining a symptom diary. So this is what we call as scales. So in palliative care, we have a lot of importance on what we call as scales. So this is called as the Edmonton Symptom Assessment Scale. In our OPD, we use this scale every single time the patient visits our OPD. So this scale is used, and this is how we know whether our medications or our interventions have worked for the patient, and we know how they were when they came in as to how they are now. Reassessments should be frequent, and so our goal is always try and bring down the symptoms to as much possible. And the definition of pain in palliative care is pain is what the patient says hurts. It is whatever ISP gives as definition. It is not how you interpret. You can't say that, oh, he's just sitting very quietly, he's not screaming, he's not in pain. But that's exactly how chronic pain looks. The person is withdrawn, sitting alone, isolated, because the pain is so intense and there's no one around to believe him. So even pain assessment, you will be doing it in detail, but you should understand that the disease causes pain, the treatment causes pain, debility and comorbidities also increase the pain. So we have various scales for it, and we try and assess the pain and figure whether it's nociceptive, neuropathic, what kind of pain this is, and then add the medications. And of course, we have scales. There's something called OPQRST, which means the onset of pain. What are the palliating factors? What are the provocative factors? What is the quality of this kind of pain? What is the radiation of this pain? And what is the site of this pain? Is it one site or many sites? What is the severity of the pain? What are the temporal factors? This is the absolute basic history taking in pain. So when we come to principles of pain management, you will definitely learn way more in this, and you will have multiple sessions. But I don't know how many of you are aware of the WHO step ladder, which we use day in and day out. We will be learning about the use of morphine in cancer pain, which is the gold standard for cancer pain, and how we use adjuvants, how we use paracetamol for pain control. So all of this will be covered in your session. The role of oral morphine, we need to emphasize this, and you will understand the value only when you work in palliative care and when you actually work with these patients. It's a gold standard. Access to oral morphine is one of the indicators for availability of palliative care services. And sadly, just 0.4% of our patients have access. And we export oral morphine to other countries. We are one of the biggest exporters. And so we need to change that, but we also need to keep checks and balances in place. And so with all our learning comes a great amount of responsibility also. The other symptoms that we manage are dyspnea, pain, cough, all of these. So when we talk about early palliative care, it means, see, all these symptoms don't come suddenly on one fine day. These symptoms are always going to be there in a patient who has been diagnosed with cancer. It could be one, it could be many, it could be mild, moderate, severe. But that is why we need early palliative care, because initially we are managing the symptoms. You do them well, and that's what builds trust. And once you build that trust, that's how you integrate palliative care. And now the patients will come to you through the course of their disease. So this is one of the articles I would really encourage you all to read. This is Early Palliative Care for Metastatic Non-Small Cell Lung Cancer. And it was this article that propelled palliative care right in the importance of early palliative care, because it said that if you treat, there's less aggressive end-of-life treatment, patients actually have longer survival. And this is what made the world wake up to early palliative care. This is Jennifer Temmel's paper. And so why I'm emphasizing on all of this is because patients with lung cancer who come to us with breathlessness and dyspnea, we start with low-dose morphine early. And that actually preserves their quality of life, helps them through treatment. And once treatment starts, they are gradually, we can even take away the morphine, because then the symptoms start, they start getting relief of symptoms because of therapy. But the role of morphine in dyspnea is so well evidenced, and we do have enough literature on it, but still the common perception everywhere is, oh, morphine, it causes respiratory depression. So these are the kind of things that should change when you do palliative care, when you need to understand the evidence, when you need to read, and when you need to learn how to use these medications. It's always start low and go slow. So it is not the lack of evidence, it's a lack of attitude, because many times we have physicians, we have super specialists and subspecialists, very well trained, but pay minimal attention to pain and symptoms. As a physician, if you do that, you really, really are not helping the patient. So if you start by talking to your patients and starting addressing symptoms along with the disease, you will make a much better physician. We have enough guidelines. GI symptoms are again huge, right from oral problems to candidiasis to stomatitis, xerostomia, all of this which happens during the course of therapy, nausea and vomiting. If I just ask each one of you, if your patient came to you with nausea and vomiting, what's your drug of choice? Could you please put it in the chat box? For your patients with nausea and vomiting, ondansetron, yes. Wow, I am so happy with that one answer on metoclopramide. There was someone who wrote metoclopramide. So once you study palliative care, then you will know that, yes, slowly I'm seeing domperidone. And so the right answer to this is, one, identify the cause for your vomiting. Your patient can come to you with vomiting because he has an obstruction. They can come to you with vomiting because this was post-chemotherapy. They can come to you with vomiting because they have brain metastasis. They can come to you with vomiting because they have candidiasis. So first, identify the cause and then give the right drug. Ondansetron will work beautifully when you have vomiting post-chemotherapy. And your metoclopramide will help when you need a prokinetic. Suppose you've given your patient morphine and you want to prevent the vomiting that comes because of the morphine, you'll give it in the first 2-3 days. You don't give ondansetron because it increase the constipation. At that time, you choose metoclopramide or domperidone or haloperidol. So why you give which drug? When do you give olanzapine? When do you give steroid? Why do I choose this particular drug is again very important in symptom management. And you will definitely have sessions on nausea, vomiting, constipation, and all of these symptoms. So focus on the cause. What is the reason for the vomiting? And then address it. So when we talk about palliative care emergencies, also learn to identify this, because if you wouldn't know, then you wouldn't identify it. You can have a patient who's come with constipation and then says that I'm having constipation, I'm having difficulty in passing urine. He could actually have a spinal cord compression. There could be someone who's bleeding from the tumor. You could have someone who's come to you with confusion and severe bone pains. You have to rule out hypercalcemia if this patient has had extensive bone mets or it's a head and neck malignancy. You can have patients with delirium. You can have patients in sepsis. So all of this could be palliative care emergencies where you have to work along with your primary physician, try and identify the cause, and then treat accordingly. And when will you not investigate aggressively? When will you investigate? These are ethical decision makings. And all of this, again, you will learn in the course of your course over the next couple months. And remember, symptom control does not only mean medications like analgesics and medications for the particular symptom. We also work in sync, especially in oncology. We work with surgery, radiotherapy, and chemotherapy because disease-directed therapy itself brings down the symptoms to a significant extent. So you can have all of these, you can use all of these modalities of treatment in bringing down symptoms. And in palliative care, care is always multidisciplinary. So one physician alone never manages palliative care. You need your nurse, which is very important, physiotherapists, occupational therapists, all of them add to quality of life. When you're doing wound care, fistula care, care of the bedridden, lymphedema care, rehabilitation, occupational therapy plays a beautiful role for patients. So it's always multidisciplinary. This is also something you're going to learn. So remember, today's session is just introducing you to the various facets of palliative care. So when we talk about integrated oncology team, you will have a palliative care specialist, you will have radiation oncology, you'll have med-onc, you'll have surg-onc, you'll have patients' caregivers. You can even have interventional pain specialists. You will have a family physician, maybe interventional radiology, rehab. All of these will contribute to the team. And then when you have touched on the physical, you should be able to address the emotional trauma. So to address the emotional trauma, again, you will have sessions. The most important element that drives palliative care is, there are 4 levels that we say. One is pity, when you look at something and say, oh, so sad. One is sympathy, when you genuinely feel bad about something, but you just feel, what am I going to do about it? Empathy is when you actually put your feet into someone else's shoes, and then you start feeling, oh, I know exactly how you feel. But where does palliative care begin? You have to have empathy, but you need to have compassion. So what is compassion? You need to have action. You empathize with someone, you do something about it. That is providing compassionate care. And that is the basis of palliative care. So you have multiple psychosocial concerns. It's not just financial. Somebody who is really, really well off can have multiple psychosocial concerns, and the other way around too. So everything becomes a challenge. And so you suddenly, what you aspired to do is just fading out of the horizon. So that can be very, very traumatic to someone. So that is where you, like what I mentioned before, are going to be co-travelers. You are not here to solve everybody's problems, but you are going to be there to listen. You are going to be there to help them find meaning in their lives. And that finding meaning in their lives is what we call as addressing spiritual distress. So you will have sessions on this, and then slowly over the years, as you practice palliative care, you will understand how intricately spiritual distress is woven into physical distress. Care for the caregiver is again very important because this is someone who's multitasking all the time. So that is also our responsibility. And when we talk of palliative care, there is something called the trajectory of care. So initially, you will have a lot of curative options. Gradually, you will have more palliative care options. And then there's something called hospice care, which is essentially for those who are, maybe in their last few months of life or last few weeks of life. And this is also followed by what we call as bereavement care, which means that a family has lost a loved one, but we are still in touch with that family to identify complicated grief, to help them through that phase also. So before any palliative care program, we need to have a comprehensive care plan. When we talk about comprehensive care plan, so just like how symptoms are in all of these domains, the physical, the psychosocial, we need to have a plan. How am I going to address the physical symptoms? What kind of psychosocial support am I going to provide this family? Now, suppose the person can't move. Will I be able to give them a wheelchair? Can I give them a commode chair? How can I help with that? So those are practical issues. If they have a Riles tube, is the caregiver trained to put in, to feed the patient through the Riles tube? Remember, this is going to be always there. So what are the practical changes that I am going to help them with? Anticipatory care. What does anticipatory care mean? It means I need to give them a little roadmap. Now, this is where you are. But if you develop breathlessness, what will you do? If this happens to you, what will you do? Where are you going to go? What is your preferred place of care? And can we make arrangements for you to be, cared for over there? Or is there an interim help place? Do you want to come back? All of this is what is, and some medications, maybe oxygen support, all of this that we give the patient, which is what we call as anticipatory care plan. And very important to know who is the decision maker, because whether the patient is a decision maker, whether the husband is, or wife is, or whether the child is, you need to document this. So in a goals of care plan that is made by palliative medicine, we incorporate all of these. So who belongs to this team? All of whom that I told you. And we also have volunteers, and you will know, especially when you work with TIPS, and they will tell you about volunteer training and volunteer training programs in palliative care too. So essentially, you should understand that palliative care affirms life. What we do is regard dying as a normal process. We don't try to fight it when we know that this disease has no cure. We provide symptom relief. It's low tech, it's high touch. It integrates all the domains that we just spoke about, and it supports the caregiver, and it's very dynamic. Don't think of it as static, because today your patient could have nothing. Tomorrow he may suddenly become breathless. Day after he may be dying. So you have to prepare the family through the entire course of what can happen, and that could be very sudden too. What is it not? We do not hasten or postpone death. Palliative care does not mean giving up. It's not a last resort. It's not like, oh, there's nothing to do, then go to palliative care. No, there is always something to do, and palliative care will do what it needs to do. It is not a substitute for curative care. That's also very important. Oh, you know what? I have heard that radiation is very harmful. I'm not going for treatment. Then you say, oh, yes, of course, I'll give you palliative care. That's not what it is. It is our duty to help them to understand what they are missing out, what is the benefit, what is the risk, and then plan treatment. It does not shut out the patient. We never tell the patient, stay out of our room, and now I'm going to talk to the relative. We involve the patient as much as possible. It is not synonymous with terminal care. So these are a few things that you should understand at the end of the introductory session on palliative care. So it's like a cloak of comfort. This is the diagram that you will see everywhere. Like when you can have disease supportive care, you can have comfort focused care, but throughout you have like a cloak of comfort, which is what is palliative care. And where can you provide it? Truly, it's a philosophy of care. You can provide it at home, in a hospital setting, in the ICU setting. You can provide it anywhere if you have the will. Principles of bioethics, you have a separate session on this, so I will not touch it now. Communication is the core and the center of good palliative care provision. And communication is not that, oh, I was born with it, or, she talks very well, or he talks very well. Communication is a skill. And communicating serious news is very, very much part of your training. So learning how to communicate with the patient is a skill which each physician needs to develop. And palliative care providers usually train in these skills. So you will have multiple sessions on communications. So I just want to touch and say that this is a very, very integral part of palliative care provision. End of life care and hospice care is one part of palliative care, not all of it. So you will again have multiple sessions on this. And any session in palliative care is incomplete if I don't talk about Dame Cicely Saunders, because Dame Cicely Saunders, if you go back and read her history, she was a social worker who then became a nurse and then became a doctor to practice palliative care. And there's a very nice history about her in the World War and finding someone who left her some money. And that is how St. Christopher's Hospice was born. Today, if we give morphine as a 4th hourly dosing, if we give chronic medication, continuous medication for chronic pain, it's thanks to Dame Cicely Saunders. So how did palliative care evolve? It started from emotion and then gradually the evidence built up. So Cicely Saunders started it, and then came Balfour Mount in the 1970s. And then there was growth for inpatient palliative care at that time. In the 1990s, and even today, you should be reading about Eduardo Bruera, because most of the integration in palliative care is his work. And that is when the evidence started building. That is, he's from MD Anderson. And of course, Jennifer Temmel's paper in 2010 propelled palliative care. And that is why the visibility, all the sessions, so much training, all of this has been happening since 2010. And of course, COVID and telemedicine and palliative care, all of this, the visibility increased way more after COVID too. So this is evidence-based medicine that we practice, is something that you should be keenly aware about. And why do we need to integrate? Because I cannot be telling the patient something and the oncologist telling the patient something else. We will leave the patient extremely confused. So that is the reason we need to integrate. So if you are providing palliative care for a patient with CKD, you need to integrate with your nephrologist. If you're providing in an oncology setting, you need to integrate with your oncologist, because there is so much that needs to be done, and how would you do it? So an integration is not just having an OP or a PC clinic, but it is a team integration. How am I going to provide delivery? What is the ideal time for me to refer? What is the need for referral? Who are the palliative care providers? All of this. So in this, we have multiple models of integration. You can have, in an oncology setup, you can have a palliative care clinic and an oncology clinic in the same place, in the same hospital. You can start providing palliative care as soon as it's a metastatic disease. You have community palliative care programs, which is predominantly what Pallium is. You can have secondary programs. You can have tertiary care centers, which have palliative care. So all of these are the various models that you will see and learn about palliative care delivery. And so then in your own space, how you can adapt and how you can start, that is where your creativity comes in. You can have complexity-based model. You can have needs-based palliative care. Like if my patient has intense symptoms, it doesn't matter if this is a patient whom I'm treating with curative intent, I still need help from palliative care. You can have, but whatever we do, this is again from Eduardo Bruera's article, and this is a very, very popular program that integrated model that he has demonstrated, where you say, when I'm saying integrated care, it means my oncologist will see me, my physiotherapist will see me, my nurse will see me, my palliative care physician will see me. But at the same time, I should be conscious that I am not going to fragment this care. I have to integrate it. So usually the best model, and that's what we follow at our center also, is that you have a primary team, you have a palliative care supportive team. So suppose there are any interventions, we still remain as that connect in between. So suppose I send a patient to a gastroenterologist for stenting, I still keep track of the patient when they come back to us and then connect with oncology. So similarly, you need to have a nice model which will work for you, which will not fragment care, but which will integrate care. And most importantly, this has to be built into the system in your hospital, because in our hospital, it is built into the system. We do it in the joint clinic. So once it's declared there, then it's the same process that follows for all the patients. But if I have a model where one oncologist decides I will send to palliative care, the other person decides I won't, then the system fails. So you need to have a system-based model, a uniform practice, if it is an institution or a hospital. So there are many advantages of an integrated model. It normalizes the introduction. So if I am seeing this patient for pain from day one, when I'm seeing the same patient towards end of life, the patient is already familiar with me. We have built trust, and the patient doesn't feel that he is being abandoned or sent somewhere else. Contrast this to a system where someone is seeing the patient as the disease, throughout the course of the disease. And one day they just tell the patient that now there is no more treatment for you. Go to so-and-so person who will now look after you. It feels like abandonment if you put yourself in that place. So that is why an integrated model normalizes the introduction of palliative care, makes the patient and family understand that all of this care is being provided along the trajectory. And also brings down the effort on the oncologist side. And also, you have a specialized program. So let us do this. You do what you're best at, and let's put all of this together. Again, basic palliative care services need to be provided even by the oncologist, because if we are going to say that I need palliative care for every patient at all points in time, we do not have so many people. So basic training is a must. Specialist training is where you can delegate. In our national scenario, if we go back and see, since 2011, palliative medicine has been recognized as a specialty by the MCI. We have a program from 2012, the national program. Since 2014, we have the NDPS amendment. And since 2017, we have a national health policy. In 2021, we've started the DNB program. So like I told you, that paper in 2010, more visibility. From 2011, our country has been way more proactive than it ever was. And so that is why today we see so many of you coming in for a fellowship program in palliative care, which is so heartening. So the take-home message from this is palliative care brings together the heart, the head, and the mind. And if you have any questions, I will be more than happy to take them. I think we have had a long monologue, and it's time for you to interact now. Thank you so much. Any questions, any of you? See, when you don't ask questions, then it can be very frightening. It's just that, you haven't really understood what we spoke, or you understood just about everything. So any questions that any of you have?
Ma'am, I have a question. Good evening, ma'am.
Yes, please.
Ma'am, generally when we provide palliative care, generally the primary physician, when they refer to the palliative care, patient is generally in the delayed stage when they are referred to the palliative care. When you talk about the early intervention, I have seen many physicians very reluctant for that. They don't agree on that part. I just want to know how come we can overcome that barrier.
That's a huge barrier. Where do you practice? Which part of the?
Ma'am, in the north, in Jammu and Kashmir, ma'am. I'm in government college right now.
Okay.
Yes, ma'am.
So actually, Jammu and Kashmir now has good palliative care centers.
Yes, ma'am.
They do have programs within the colleges. So remember, it's slow and steady, because
Yes, ma'am.
these are the challenges. But very honestly, what we saw, 10 or 12 years ago was way more. And what we are seeing now is there is more opening. So it's the younger physicians, the younger set of people who are a little more open in their practices. But you are going to have this. So the best way to do it is, and what are you? Are you you're in what capacity do you work in your hospital?
Ma'am, I work as a palliative care physician there.
Okay. And this is a general hospital? It's a private or a government or what?
Ma'am, it is government facility.
Okay. And you are working in the palliative care department?
Yes, ma'am. No, not as, but a part of radio-oncology. I'm working with the radio-oncology as a palliative care physician. They refer to our palliative care unit. Yes.
Okay. So you mean radiation oncology?
We work in collaboration with radio oncology.
Okay. So the best
Yes, ma'am.
way is make your patients your ambassadors. Start treating the symptoms. So the first step
Okay.
is what you've already done. You're training in palliative care, you're working in a palliative care unit. Start doing the simple things. Deal with pain, deal with odor, and make friends with the nurses, with all your other staff. In the sense,
Mhm.
they are going to be your ambassadors and it's your patients who are going to come back with you. Don't counter what your specialists tell you. If they send you patients towards end of life care, look after them. But you have an opportunity if you're working in radiation, if you're working in radio oncology, if you see a patient with symptoms, start with symptom control. No one is going to object to that. And make your work speak. And another thing that you can do is small audits, small research activity. Your research audits, these are the things that they are going to listen to. When you have your faculty forums, when you have your CMEs, or any of that, do small audits or make a journal presentation. You have so much literature now. So bring in the evidence because that is the language they understand.
Yes.
So you need to bring in the evidence, but you also need it to make it a healthy session. It's not like you're not doing this. It is just like, let us do this also. And always use the word us. When it's we, when it is us, it is always more accepted. Rather than I will do this, say, could we do this?
Yeah.
Just
Thank you so much, ma'am. Thank you
because
so
what
much.
you are facing is a reality in our country. It is everywhere, not just in our country, in the world in different levels, but in our country for sure. But slowly, the inroads that have been made are significant, and I'm sure you can do it.
Thank you so much, ma'am. Thank you.
Good evening, ma'am.
Yes, please.
Yeah, actually, I'm an anesthesiologist. I'm doing anesthesia practice since last 25 years or so.
Okay.
We do have a lot of onco cases in our hospital, like 100 cases, surgical cases per month. So from where to start? I am hardcore anesthetist, and now I want to shift towards palliative care. So,
All right. Very nice that you're a hardcore anesthetist shifting to palliative medicine. So you could start with interventional pain. So you could actually train in interventional pain and blocks because that's your strength, along with training in palliative care. Do you have a palliative care support in your hospital?
No, madam. Right now,
Okay.
no, sir.
So then slowly build a team. You have access to opioids for sure, but do you
Yeah.
have morphine tablets? Because I know that
Yeah,
you will have
yeah,
IV.
yeah. We do have.
Will have access to morphine tablets. So you could do it in multiple ways. You could deal with post-op pain. You could start a transitional pain service, which is what you do in post-op pain. Then you could have chronic pain patients or start a chronic pain clinic twice in a week or thrice in a week, however your time permits you. So keep it as, a chronic pain clinic. And that is where you will slowly start seeing these patients. It could be post-radiation, post-surgery. It could be disease-related, patients on PAL chemo, patients who've completed PAL chemo. So you just label one, like how you have PAC. Similarly, you have a pain clinic.
Right, ma'am.
And if you have a pain clinic, that is, you started as a pain clinic, and from there you start practicing pain and palliative care. Or you could label it as pain and palliative care clinic also, and slowly start, because I don't know what freedom your corporate setup gives you. Some of them don't like the word palliative. So you can start with pain clinic and then incorporate palliative in it. And also you have a beautiful opportunity if you also manage your ICU in practicing good end of life care. So when you know that it's futile, and recently we have got guidelines, the ICU guidelines also. So start by, end of life care practices, guidelines for that, use the ICMR protocol, use the most recent protocol. Don't intubate patients who are terminally ill. So how you deal with them? In all these ways, you're practicing palliative care.
Right,
So
ma'am.
you could use any of these.
Thank you, ma'am.
You're welcome. I saw a question which spoke about psychiatry and palliative medicine. Where is there scope in psychiatric illness? Yes, there is. In fact, psychiatry and palliative medicine have a lot of parallels. They have a lot of things that they go hand in hand. And I don't know which psychiatric illness you're talking about, but palliative care can definitely be a support, even if not directly to the patient, but also to the family. Because the families of patients living with psychiatric illnesses are also traumatized. It's a very difficult phase. So yes, there is. Schizophrenia, you have to work with your neurologist and your psychiatrist for that. And definitely palliative care can help in caregiver support and in all the non-pharmacological methods of care. There is an interface there too.
Good evening, ma'am.
Yes.
I'm Dr. Jaiswal, based in Kolkata. So my experience has been from anesthesia to pain and now to palliative care.
Wonderful.
So but what I feel, the barrier that I face regularly is the integrated approach that you spoke about. Because I do have people referring me to my pain clinic, to my palliative care clinic, but the integration part is very difficult. Like, I give my advice, but then they say something else. And it's very difficult to convince the patient to follow what we want them to do. Because sometimes we have to tell them, okay, you follow what the oncologist or the primary physician is telling you to do, but you can follow what we are saying, because that integration becomes very difficult with them. So how to...
So what kind of a hospital do you work in?
No, I am associated with an NGO, EIPC, which is being taken over by Pallium. So now Pallium is coming into the picture. But it was just a small NGO where we have OPD. We do not have any inpatients over there. And we provide morphine to the patients, and we also do home care.
Okay. So now what happens there is when we talk about integration, you have to start from where they are. So an integrated approach always works if all of you work from the same place. Because if you are running a separate home care program, it is hard for an oncologist who has patients under his care to refer them to you in your home care program for symptom control, especially when they're giving chemotherapy. So integrated care usually works when you are, that is why the kind of model that you're following is very important. So how integrated care can work when you have an NGO setting is if the hospital is connected to the NGO, if you have an MOU with them, if you have a formal MOU with them. And this is very hard when a patient is taking chemotherapy because they are sitting in another place, not knowing what somebody else is saying. But an integrated model works very well when both teams are in the same place. So when you are running your program from within the hospital, but you may be tied up with an NGO. So where your program can succeed even now is if you have an OPD in the hospital. You may have an NGO with home care, but if you have an OPD in the hospital, that is when your patients are seeing the oncologist and seeing you in the same place, and you have an OPD in the hospital, that is how you start integrating. It becomes easier. Otherwise, if you look at it from the oncology perspective, how difficult it would be for him or her. They are giving chemotherapy or disease-directed therapy, and then someone tells them from the periphery that this is what you have to do for pain. They may not even know who you are, which I don't know how you work, but they may not know. But if you're in the same place, you meet them more frequently, you discuss patients with them. So, and one more thing that can help is if you physically talk to them, which I'm sure you must be doing, and you say that, so-and-so patient, maybe we could try this, or we have started the patient on this. And another thing which you unfailingly can do, which is always helpful, is tell the patient that even when disease does not have treatment, we will be able to help you. So that one word line, if you tell the patient from the beginning, remember when they need you, they will come to you. So at least you don't lose the patient, or the patient doesn't lose you. I would actually say it the other way. Otherwise, they get lost in between. So integrated care is always from both sides, and you have to build it from scratch. In our hospital, it was fortunate that our OPD was set up right at inception. So medical oncology and palliative care OPD came together in 2015 when the hospital started. So which has made integration way easier because we started working together right from there. In fact, radiation surgery, everything came afterwards. But we were the two departments who were there existing right in the beginning. But you can definitely do it if you have an OPD in the place where they are. But if you have just an NGO program and then a hospital, it's a lot, especially if the patient is on active treatment. If the patient is not on treatment, gradually they'll come to you. But even when they're in active treatment, tell them that we are there, we will help you. Any symptom, reach out to us, reach out to us.
That's what I do. That is the only thing that we can do now.
That's the thing that will bring them to you. And otherwise, you can have an official MOU with them. That also works.
Thank you, ma'am.
Yeah. Dr.
Yeah,
Arjun,
good evening,
anything?
ma'am.
Yeah.
Good evening, ma'am. This is Dr. Suhaila from Abu Dhabi.
Huh.
So it was excellent, informative presentation class rendered by you. So I am working in a medical center. We are rehabilitation medicine specialist. I am.
Okay.
So is it mandatory that in order to start palliative medicine practice, we should have access to morphine medication, because there are a lot of restrictions to get this medicine in UAE. So
it
we are
depends on what
treating.
center. Sorry, continue, please.
Yeah, ma'am. I'm working in a rehabilitation center. We have mix-up of patients like chronic pain. As you said, palliative medicine can be practiced for any chronic conditions, neurological entities, and even cancer patients we do have, they come up with metastasis with spinal cord injury and spinal cord metastasis with paraplegia, quadriplegia, and so on. So we are giving them, we don't have access to morphine in UAE. Only in tertiary centers it is available. So is it mandatory that once we practice palliative medicine in our center, we need to have access to this kind of medication? So we are managing with tramadol, paracetamol, and other opioids like that. So once I start practicing proper palliative medicine, will it be a barrier to give results to the patients?
I would say that it would be difficult when you're talking about spinal cord metastasis and you're seeing patients in oncology. It's not going to be easy, because at least in oncology, in severe pain, morphine is the gold standard. So would it be possible for you to have a tie-up with one of the tertiary centers where you can send them and then monitor the patients if they can get the morphine from there, and then you can monitor them? Would that
Yeah,
be
that will
possible?
be the only option for us.
Yeah.
So, yeah, we'll try to do that. Another thing is hospice care and palliative care. Palliative care we can apply in any chronic disease, but a hospice care, we do get some patients from tertiary center for terminally ill patients with DNR status, do not resuscitate kind of. So these kind of patients should be categorized under hospice, or what is the
So,
demarcation?
yeah, so when we talk about hospice care, the definition is not uniform all across the world. So in the US, they define it separately. They say if you prognosticate and say a patient is less than 6 months to a year to live, that is when hospice care. That's because in the US, it's predominantly insurance driven. Whereas in UK and in Europe, they have a very clear pathway. So they have, like, for these reasons, you will go to the hospital. Now you will be on home care. If not on home care, then this is the hospice you will go to. This area will have this hospice. So that's how it is. It's not time bound, but it is based on the goals of care, which is actually how a hospice care should be. In our country, we have very few hospices. So in some of our hospices, we even call them as respite centers, or the hospice that we work with in our area. Till we had beds, I mean, this I'm talking about a few years ago, we would also use the hospice for respite, which would mean like the patient is going through maybe a patch right now where the patient is really down, has an episode of sepsis. We admit the patient in hospice. Goals of care are definitely palliative, and patient will be DNAR status, but it's not that the patient is not going to come out of that episode. He can come out of that episode and again go back into the hospice for admission. So essentially, hospice is it is a place where you are able to provide all the domains of care. So you have good physical support, you have good volunteer support, you have good psychosocial support, you have a counselor, you have a social worker, you have somebody to look after the caregiver needs, you have somebody to give caregivers respite. So essentially, that is what a hospice is. And when we talk about rules, the US, of course, has its rules, but in our country, we still use hospice for respite in some cases. But otherwise, we have Karunashriya, we have, Sipla hospice, we have hospices in different parts in Tamil Nadu also, where patients who are essentially terminally ill are admitted. Also, some hospices take in patients with long-term needs. So you can have someone with paraplegia or with quadriplegia and who has intense nursing needs, but they are not essentially terminally ill. So that is one more bracket of patients that you have. So hospice is not like, I can't say that this is the definition. Depending on where the patient is and the facilities you have, it kind of changes. But regarding your morphine, tramadol, I mean, non-cancer patients, you will have, there are a lot of adjuvants that we can give for pain. So using adjuvants, I'm hoping the sessions that you will have and the adjuvants that you will use will be of help to you when you're dealing with non-cancer pain especially. But in cancer pain, it's hard to do without morphine. You may not need it for all patients, but when you need it, you need it. Would you have access to methadone? Would you be having any access to methadone over there?
No, ma'am. In only tertiary centers.
Only tertiary centers, then you'll have to have a tie-up.
Yeah, we have Cleveland Clinic and all. They have established pain clinics. So
Yeah.
we'll have to tie up with them.
Tie up with them. But it must be very difficult. Not
Thank you.
Hi, ma'am.
Yes, ma.
Hi, ma'am. This is Dr. Vinita. So I had just completed my PG in community medicine. And
Okay.
it's been like, and I joined as a senior resident. So my this one is that even during case presentation of case, I have not come across come across anything which is very palliative related, and it was very difficult for me to take a case that I've seen to make it into a case presentation. So my point being, as a community physician, what will be my role in this palliative team? Will I have a preventive oncologist or something like that to work with?
So where are you working in community medicine?
I'm working in Manipal University, ma'am, Bangalore.
Okay, if you're working in Manipal, then you will have support. You will have, if you're in Mangalore and in Manipal, then Dr. Sheetal is there. Pallium themselves will help you. She's associate professor in medicine, and she can definitely help you, and to make inroads. But we work very closely with preventive oncology over here, because in all the sessions in preventive oncology, I take a session in palliative care, because remember, preventive oncology is reaching out to the community. Now, when you told me that a case is difficult, I want you to now, with this background, step back and think. Did you ever see patients with CKD? Did you ever see patients with chronic respiratory disease? Did you see patients with neurological diseases? Did you see patients with Parkinson's, dementia, any of these? Did you see patients with CHF? So think.
Yes, ma'am.
These could be your potential patients, okay, or your case descriptions. Because remember.
But for me to give the treatment and the medication, that was very difficult because we were not able.
Yeah, so you will learn when you will be doing these courses. There will be sessions on non-cancer palliative care. But remember, you can always work with the primary physician. You can do so many other things, like, so you have non-pharmacological methods. You have to sit and talk to the family, make them understand what the disease is, and the social problems that they have. That is your strength as in preventive medicine, because that's what you do most of the time, like going out into the community. We work very closely with preventive oncology because the same people who go into the community can also identify those with palliative care needs. So if you know what palliative care is, then you will be able to identify patients with palliative care needs and align help for them. So that's another thing that you can definitely do. And if you're working in KMC Mangalore, you must meet Sheetal, because she is actively working in palliative care, and I'm sure you can work with her. Does that help? Anita, yeah.
We have a similar question, Mike. How, as an orthodontist, she can help, Dr. Anushree Jati, she can help in palliative care?
So I would go one step back, because before you became an orthodontist, you were a dentist. So as a dentist, you have excellent hold over oral anatomy. So any of our patients in whichever part of our country you work, you will see so many oral cancers. So you could kind of, if you could support patients with oral cancer, depending on the hospital where you are in. I don't know your setting, but that is one area you can definitely help. And in fact, we reach out to our prosthodontists very often because you have patients with fistulas. So if they could, give them something which will act as barriers. So all of that is something that we reach out to. We have a dental surgeon in our hospital. So any cancer hospital needs a dental surgeon because osteoradionecrosis, pre-RT checkups for patients, all of this is what is done by a dental specialist.
हाँ एक बार बंद कर दे बेटा.
Can any doctor with MBBS degree prescribe oral morphine?
Yes, you can, but you will have to be trained. And so that is why you're doing this course. But it's not like I finished my MBBS, I'm eligible to prescribe. You can definitely prescribe, but remember, you need to train. And with your prescription also comes the responsibility. So how are you going to maintain those records? How am I going to prescribe? How much medication am I going to give my patient? How am I going to track whether the patient is taking all of it? And keep my records in place. All this is something you have to learn, and you have to also, most importantly, learn everything about morphine, how it is absorbed, how it is excreted, and which kind of pain you will give morphine. All of that is very, very important. So that is why these sessions will help you.
I believe that many of you have many more questions to ask.
Yeah, I'm sorry I didn't look at the time. So
yes, ma'am. We have to
carry
move
on.
on to the case presentation. Don't worry, you can just put in your queries into the group, and we will help you to connect with Dr. Vidya and definitely clear your queries.
Yes.
So moving on to our case presentation.
Dear team, we are moving down to the case presentation part. I know many of you have some doubts regarding the same, which you have asked me in the group also. So please listen this carefully. So Dr. Arjun is going to have a case presentation.
So this is regarding a very elderly female, 85-year-old, who was suffering from advanced COPD, presented with an acute infective exacerbation. She was also suffering from hypertension, diabetes, and a CID. She presented with severe breathlessness, which was even worse at rest, unable to perform her activities of daily life. She had severe tiredness. She was unable to sleep and loss of appetite. So coming to her history, she had diabetes, hypertension since more than 30 years. And she presented initially with small coughs and breathlessness episodes. Around 20 years back, she goes to a nearby clinic, takes some symptomatic treatment, no relief, and multiple hospital visits were done, and later was diagnosed as COPD. She had recurrent hospital visits due to infections throughout these years. And in last 1 year, she had 3 ICU admissions with severe exacerbations. So when we saw she was drowsy, very emaciated, all cavity was dry, bilateral cups was there, and bilateral pitting edema was there. Regarding her treatment, she had poor drug compliance. She often stops medications when she has some relief. Multiple sessions were performed for need for drug compliance, not adherent to MDIs, the meter-dose inhalers. She's currently admitted in an intensive care unit of a tertiary care center, receiving high-dose antibiotics and non-invasive ventilator. Due to worsening of her condition, they were planning for invasive ventilation. So psychosocial aspects, she was a homemaker, living with her son and daughter. Husband expired, unfortunately, 3 years ago. Son, being a coolie worker, is the sole breadwinner for the family, taking care of the mother and the daughter. She often some concerns like why God punished her. She doesn't want to be hospitalized, rather in a ventilator. She wants to spend the time, whatever she has at home. Bronchodilators have been optimized, the optimal dose has been reached, the beta-2 antagonist, steroids, anticholinergics, but unfortunately, she is still breathless. In last year, she had 3 times required ICU admissions, and last time she was in ventilator for 4 days. But she doesn't feel any improvement with that and is afraid to go back into that. Major concerns are businesses, ICU admission, financial constraints. So the discussion points that we want to have is the first thing, does she need palliative care? We would like input from each and every one of you. Do you think this lady require palliative care? Yes, everyone says yes, thank you. And why do you think she needs palliative care? Her choice should be respected. Blood vessels.
Hello.
Yes, sir.
Hello.
Yes, sir. You're audible. Please.
Am I audible?
Yes, sir. Yes, please. Mr. Surinder, you're audible. Can you kindly unmute?
Am I audible, sir?
Now you are well audible, sir.
Yeah, she need palliative care, but as the patient has earlier 4 time visit in ICU admission, visit and as well as the treatment in ICU, and she psychologically now she is financially and psychologically in both ways she is unwilling to continue her treatment, and most probably she has lost her will to live. So psychologically, spiritually, she need some kind of help.
Hello.
Hello. Yeah, I'm not audible. Hello.
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 Doctor.
Hello.
Yeah, we can hear you.
Actually,
We
sir,
can hear
here
you.
some
She comes under geriatric population. She is having diabetes mellitus and hypertension. And also she is having chronic respiratory disease with acute exacerbation several times in a year. Hello.
Yes, ma'am. You are well heard.
Sorry, yes.
Anybody wants to add more to this?
there is
Yeah.
some problem there.
Yes, I think definitely she needs palliative care because she's a long-term COPD patient with other comorbidities, and she had several ICU admissions also. So therefore, she is a candidate for the palliative care.
Sir, hello.
Yes, Manisha, madam. You are.
Yes. So by the definition of palliative care, any person having a life-limiting or a life-threatening illness is a candidate for palliative care. So definitely she is a candidate. And depending on her concerns, we can address whatever concern she has and give her a better quality of life.
Sir, I'm Dr. Rosa. We supposed to educate her about that spirometry and respiratory exercises and pranayama and talking much time, spend the attendance with her, sometimes deviate from the disease, sir. Because that attacks are severe, no, as the respiratory attacks. She may afraid of that attack. So diversion of mind also needed.
Thank you, everyone. Thank you. So I've seen, we can see many of you are going to all components of the suffering. Yes, she does need palliative care. Coming to the definitions, yes, she is suffering from a serious health-related suffering. So coming to the components of her suffering, let's break her What do you think are the physical suffering she's facing now?
Breathlessness, diabetes.
Yes. Breathlessness. Trauma of attending hospitals regularly is main concern. Breathlessness. Madam Vidya madam, can you enlighten?
Okay, so many of you have put your thoughts in the chat box. So one is, all of you have said a lot of things. So just to sum up the whole thing, and many of you have said most of the things which are right. So we need to understand that how components of suffering are significantly in the physical domain, because someone who's insanely breathless all the time and who's getting admitted 4 times in the ICU is having a very difficult time with her physical symptoms. In addition to that, she is seeing that those ICU admissions are not giving her relief. She comes back and she goes again. So that is the reason why she says, I just don't want to go anywhere and just leave me. So first responsibility we have is to bring down her suffering. So someone mentioned infective causes. Yes, you should rule out infective causes. So you will be having sessions on breathlessness. Usually we reverse whatever we can reverse. So if it is infective, we deal with it. We deal with her COPD. In patients like her, low dose morphine works beautifully, and that can bring down can give her adequate and good symptom relief. We have evidence for role of low dose morphine in COPD patients, and we give her that. We make her. So now you go through the comprehensive care plan that we discussed. Physical, psychological. Physically, we try to bring these symptoms down. And so we give her low dose morphine, we adjust her medication, all of that. Psychologically, we try to spend time. I mean, the children can spend time with her and address her concerns. And you will learn anxiety is a big cause for breathlessness. So we might have to bring that down. You will find the various interventions that will need to be done, put her in a familiar setting. Practical interventions would be oxygen provision at home. She could have that at home so that it will facilitate less visits, and also connect her to a palliative care service which has a home care service, which will again help her. So these are practical ways. Anticipatory care plan. What will she do in an episode of severe breathlessness? What will she do if she becomes unconscious? What will she do? These are things that we need to discuss with the family, and who is her decision maker. Is it going to be her or who in the family? So definitely this person needs palliative care, not just because I am tired of going to the hospital. She's saying that because the symptoms are not controlled. And we know that there is no cure for this. So definitely she fits into, she needs palliative care, good symptom control, adequate psychosocial support, and a proper nice home care program where she can be managed at home. So these would be some of the things that would help her preserve quality of life. I can see a lot of your statements, which I have been trying to read on chat, which is really, really nice, because there are some nice statements like whatever treatment she has taken has not been curative, but her symptoms continue. So which is probably the cause for her distress. And as much as we need to respect what she says, she's absolutely right that this is where she wants to be, and we know that we can't cure her, but giving her physical control of her symptoms also is very, very important, and planning for her end of life care. Okay. Yeah. Would you like to add anything, Dr. Arjun?
You have covered almost all the points, and everyone has put in their inputs. So just a few things to add, like this is a situation where not just the disease, also the treatment add-ons to the suffering. Like definitely she is someone who is the candidate for mechanical ventilation, but will that help her is the question. How it is going to improve the quality of her life? If she has already been thrice in the intensive care unit, and once ventilated, she has gone through all those suffering she had, and she definitely has expressed that she hasn't felt any improvement after the intervention. And psychological issues, like you have mentioned about the anxiety, the depression. Anxiety definitely worsens breathlessness, being away from a family, the loved ones, being in an ICU bed away from them. The family itself, like looking at the caregivers, they won't be knowing what is happening with the mother inside the room. So that can raise tensions between the team, caregivers and the clinical team. Financial constraints, like our country being where a large number of people who are at the brink of falling into poverty with this medical expense alone, such a futile intervention will just add on to financial constraints of the family. She might be anger, like anger could be there. Like her diagnosis took almost multiple hospital visits and large amount of money spent. Spiritual issues, she has expressed, why me? What did I do to suffer this? Why am I being punished? She might be having multiple spiritual issues. So listening to her would be the best thing that she might need. Does anyone else want to add anything more?
I have a question actually.
Yes, ma'am, please.
Hi Vidya ma'am, I'm a medical oncologist. Basically, I got trained from Tata Mumbai. So in oncology, most of the times we will be able to draw a line to call it off, like from palliative chemo, stop it, and then take it over for palliative care and end of life care. But in patient like this, where she's like a COPD and she has been intubated thrice, but she has come out very well all the 3 times. Even though according to her, it has not helped her. But if we think as a physician, because she was intubated each time, probably she must have had the couple of extra months she had lived through and she has reached a point now. So whether this, like this episode, if at all we go on aggressively treat the underlying infection, what if she makes through the intubation ventilator again? So like how do we decide basically, since this is not an oncology perspective, I am not sure. So I'm just as a caretaker, what I should think. That's my question.
It's a very valid question.
Very, very valid question. Dr. Arjun, you want to take it
No,
first?
ma'am, I'll talk after you.
Yeah, so that's a very valid question. And exactly like you say, in oncology, that's why when we showed you the trajectories, we saw that sharp decline, which we see in our patients, which is easier. But when you're dealing with COPD, when you're dealing with CKD, so you will have multiple sessions on ethical decision making. You will have sessions on prognostication. One very key feature in this is 4 hospitalizations in the last 6 months speaks of, your prognostication is poor. It is a clear indicator. So these are evidence-based guidelines that you have. And then what are her labs? What is her age? Treat the reversible, yes. So if there is an infection, you can go ahead and treat it. And remember, you said that we are giving her 2 months, we gave her this was because of the intubation, because she came out. As a physician, you think she did well. But as a patient, how does she feel? When you are breathless 24 hours of the day, you are not feeling good at all. So again, one more bias we have is if I say I'm going to start morphine for this patient, it means I am going to cut short her life, which is not true. Okay, if you actually see how many patients can live with low dose morphine, and this is a very, very, in COPD, it's a very, very low dose that is given. We put them on SR medication even once a day. We see what is the dose that works for them. We put them on that, and along with oxygen support, and we also use non-pharmacological interventions. So in every patient with breathlessness, there are non-pharmacological interventions, teaching them simple breathing techniques, teaching them to pace their activity, teaching them how to rest, all of this actually improves their quality of life. So by denying them that ventilator, I don't want you to think that you're taking something away. You're actually giving them good days. Again, how much to go is always on prognostication. So treat the infection. You can even use the mask. You can use, but ventilating and intubating her, that is what is called ethical decision making. And we will be doing it subsequently in one of the sessions where you need to have this grid in your mind. Medically, what is it that I want? What does the patient want? How much is the patient ready to take? And how much is this going to help? So that grid is important. And what if she goes into the ICU and develops delirium? What if she doesn't come out of that? Then so it's that benefit risk, and you know best, giving chemotherapy and being a medical oncologist all day and night, that's what you do. But like you rightly pointed, it is definitely more difficult in patients with COPD because they have had exacerbations and come out of it. But if you have had 4 exacerbations in the last 6 months, it means that you're on a declining trajectory. So what is it that the patient would want? What is it that I would want is very, very important. So having that conversation actually gives you the answers. So I don't know if it has answered all your questions, but it's a process.
Yeah. Yes, ma'am.
Yes. It's all about the quality of life, that what she expects to have. For her, it might be something.
Ma'am, is morphine not contraindicated in respiratory distress? Hello?
Madam, you are muted. Dr. Vidya?
Yeah, so it will be done in your session on breathlessness. So you will learn how you can give low-dose morphine for symptom control in patients with COPD who have breathlessness as a significant symptom, just like how we do in cancer. Okay?
Yes, ma'am. Ma'am, actually, we have a lot of patients with acute exacerbation of COPD nowadays because winter season is going on in North India.
So
that's
you
why,
should know
ma'am,
when to give. Okay, you should know when to give and when to start. So you will be doing.
Yes, ma'am. Okay, ma'am. Thank you, ma'am.
Dr. Shivam, you wanted to ask something?
Yeah. I want to highlight a question that you have told that she has been admitted 4 times in last few months on ventilator for last time, but you have not highlighted the indication of ventilation, whether she was having type 1 respiratory failure or type 2 respiratory failure. May I know about it?
I think it was type 2 respiratory failure. I've seen a few. Excuse me.
I want to know the indication of invasive ventilation, why she was put on invasive ventilator.
So she, many a times I think she came with exacerbations, and she last time I believe she had type 2 respiratory failure.
So here I want to highlight a point because she was having pain, so she might not be taking respiration properly. So in that case, she might have, due to improper respiration, she might have breathlessness. If in this case, we may give morphine. Along with that, after excluding infective causes, we may think about that if we relieve her pain, then she might take proper inhaler and those things. So she should not be needing regular admission, and along with that we should also think about using BiPAP in home if possible, because it will substantially decrease the hospital stay and may also avoid hospital stay. It may also improve her quality of life, so that her total scenario, her thought process and pain will be relieved, so that we may decrease her hospital admission also, and we may also give her some moral boost that your quality of life is better.
Those were very, very good points. Very good points. And good symptom control improves compliance to treatment also. So you brought out some really good points there.
Thank you.
Many a times it was her reluctance to use the MDIs initial periods. It was a social stigma to use MDIs. That's one of the things that she expressed when I asked her about non-complaints. Sorry, Dr. Biju Jacob, you have raised your hand.
Yes. I have a, sorry, it may appear very basic or a question. Is there any reference material or some, because on this palliative care? Maybe there will be some articles on the net, that is okay. Some textbooks, some academic inputs or something on palliative care. I thought this is the first class and to have an idea on that.
Yes, sir.
Like other subjects, like other medical subjects, do you have a, rather, put it blankly, is there a textbook or what do you call it? Other than the articles which you can, if you do a Google search, you will come across many articles.
Yes, sir. We have a large number of books.
Dr. Biju Sripriya this side, if I may take up that question. Yes, we do have the Indian Primer of Palliative Care authored by Dr. M. Rajagopal. We will be uploading that in the IECO platform by tomorrow. And then we'll be sharing other materials also. So definitely we do have reading books. We will be uploading it.
And just one more thing, we will be getting are we sharing this PPT which ma'am has presented today or something?
Yes,
We will be
getting.
getting.
PPT will also be shared in PDF format. You will get access to that as well.
Okay, thank you.
Namaste, everyone. Thank you so much for the case. I'm a practicing physician here in Nepal, and this case is something that we come across very often. I just was so touched by this complexity of the case because, with due respect, I see that the bread owner was a coolie, if I'm not mistaken, which is a hard-earned money that is going for the treatment of the patient, which likely is bringing a lot of financial burden to the family. For all we know, probably we would really want to explore why the patient doesn't want to really get admitted again or ICU or be ventilated. I'd not be surprised if the mother is feeling that she's a burden to the family. And I'd not be surprised if she says that I don't want to be admitted, I don't want to be ventilated. That's going to be even more disastrous for the family member who's giving all that blood and sweat to support the mother at these end times as well. So it's really such a complex scenario. So for me, perhaps the best way to go about would be a nice family conference where we can really discuss with the patient, not just the patient, but the family and all the caretakers involved, and perhaps come to a consensus as to what our goals of therapy would really be until till what level we are going to go for the active medical treatments, how we are going to plan even the end of life and even beyond that, because as we have discussed, palliative care encompasses approach that involves the family as well. Even after the patient, the family is still going to be there. So in reality, if we could really touch upon these things and we could really support, yes, as a physician, it's really there that, like we can always talk about azithromycin being given alternate day that can probably help reduce the exacerbations. We have newer drugs now that can do that. Of course, we'll do all those things, but these more sensitive areas is probably where we should probably try to dwell a little bit more. Just my feeling. Thank you so much for the time.
Thank you, Dr. Deepak, to add this wonderful words. So this is one thing that we have to we'll be facing many times. The family will be so out of love. They will be ready to spend everything on, and they would like to pursue curative management to the maximum extent possible. Many times when even if the patient doesn't want to, so many times we have to face them and convince them what is good for the mother, the patient. So this is some issue that we'll be facing, and which I hope will be covered in our communication session, which is coming up. Anybody else wants to add on anything? Dr. Vidya, ma'am, you want to add anything else?
That's all. What you just described, Dr. Deepak, is what we call as shared decision making, which is what we do in palliative care all the time. And it's very relevant in ICU palliative care where you have family meetings. We do it in oncology setups where the primary physician, the palliative care physician, whoever is responsible for the patient, along with the family and the patient, that's how decisions are usually made. So very valid. And it's really nice to see that at the end of 1.5 hours, we still have 79 participants who are still waiting to ask questions. So that's a very good start and a very nice thing for palliative care.
Such an enthusiastic crowd we have.
So from my side, it's Happy New Year once again, and reflect. That is the word you will learn in palliative care. Reflect every day on your practice, what you did well, what you could have done better. Thank you so much for your attention.
Thank you, ma'am. So please send in your queries or doubts to the group. We will try to help you as much as we are possible. So shall we wind up for the day?
Yeah. Thank you, Vidya madam, for this lovely session and the lovely words. And thank you, Dr. Arjun sir, for the facilitation part. So thank you all for actively participating in the session. We will meet you in the next session. Happy learning.
And a very happy New Year.
Bye. See you.
Bye.
Happy New Year, everyone. Namaste.